Hello, welcome everybody to the 2021 Melanoma Research Victoria Scientific Exchange. Really the highlight of the year for Melanoma Research Victoria, and we're thrilled to have you all being able to join us this evening. My name's Professor Grant McArthur. I'm a clinician scientist and I chair the Melanoma Research Victoria Governance Committee. Can I begin the evening by acknowledging the traditional owners of the lands at which each of us are present, and pay my respects to elders past, present and emerging. This evening I'm joining you from the Wurundjeri lands of the Kulin Nation, and also wish to pay my respects to any First Nations people who are joining us this evening for this webinar. Now, I'll kick off with a presentation about Melanoma Research Victoria, really a status update for you all. So just bear with me while I share my screen. Okay, so Melanoma Research Victoria, we're over 10 years old now as a resource and cohort study to empower research for researchers, not just here in Victoria, but really worldwide. And in fact, we have collaborators that have made use of the very generous donations of our resources, the clinical data that all of you, the participants, generously provide, plus access to excess tissue following a diagnosis of melanoma from biopsies and resections of melanomas that researchers can also access. So I just want to acknowledge all of the participants joining us this evening and their contribution to what is a remarkable resource. Now, let me fill you in firstly on the evening. So I'll give you an update as to some of the progress and things that are happening with Melanoma Research Victoria. Then we're going to hear from my colleagues Damien and Mark Shackleton about a very exciting area. So one of the areas of melanoma research and treatment that has been somewhat left behind, so to speak, is Uveal melanoma, and Damien and Mark will explain Uveal melanoma to you, but progress is happening. I'm finding it very exciting, and so we're thrilled to be able to talk about that tonight. We have a State of the Nation report about to be released, and the chair of the Melanoma Research Victoria Consumer Reference Group, Alison Button-Sloan, will give a consumer's perspective on the State of the Nation report and of the disease of melanoma. Throughout 2020 and 2021, there's been some challenging times in healthcare and some concerns regarding reduction in cancer diagnosis. So delighted to have my colleague Victoria Ma give us an overview of melanoma in Victoria over the last couple of years. And then what is a real annual highlight for Melanoma Research Victoria, which is to be able to host the award of the Morgan Mansell Award. This is a very special award. My colleague Mark Shackleton will explain to you the details, but we've got the cream of Victoria's young melanoma researchers presenting their research to you tonight, and that is going to be a real highlight for me. So just a brief update on Melanoma Research Victoria for you before we kick into the scientific presentations. So we're delighted that now 3,435 patients have participated in Melanoma Research Victoria and given their consent to really power the next generation of discoveries and the science to improve outcomes for people with melanoma. So these are some interesting statistics. So surprisingly, 13 patients out of those over 3,000 actually didn't have a diagnosis of melanoma. And, you know, that can occur because of change in diagnosis that sometimes occurs, or a anticipated diagnosis didn't turn out to be a melanoma. Disappointingly, 782 of our participants, have passed away that enrolled on the study. Not all from melanoma, of course, but nonetheless, that is sad, and it's something that drives all of us to reduce that figure as fast as we can. Almost 80% of people have access to email, and one may be surprised that that's not higher, but in fact there is quite some disparity in access to technology in our community. And one of the things that we are interested in is equities of outcomes and access to research and to treatments for the disease. 234 of our participants have had another malignancy. So melanoma is a very common malignancy in Victoria and Australia. And so that is nearly all by chance association, but that's a significant number. And bearing in mind just how common melanoma is in our community, 16% or over 500 of our participants have a family history. Now I'm going to walk you through some data. I'm a bit of a data nerd, I'll have to confess, and we are about to put up on our website some of the metrics and data that we have that researchers can look at and decide whether they can answer their research question through collaboration and access of the information with Melanoma Research Victoria. Okay, so these are the stage of disease out of that 3,435. The single biggest number is early stage melanoma, but you'll notice that 812 of our participants have had stage 4 or advanced metastatic melanoma. And this is, of course, an area of huge need, and so that's a very significant resource that we can contribute to this battle to try to improve outcomes for melanoma. Excuse me. So this is a metric that greatly excites me as a biomedical researcher trying to think about new treatments for melanoma, and that is that there are almost 13,000 tissue samples from surgery or biopsies. This is quite a remarkable resource and can really power that next discoveries of new targets and potential treatments for melanoma. As I mentioned, the Melanoma Research Victoria has been running now for over 10 years. And so we have now over 1,000 patients with more than 5 years of follow-up. And this is important because some melanomas, particularly thin melanomas, which overall have a very, very good prognosis, but if they do relapse, they tend to relapse later. And so to understand about relapse of melanoma, we do need long follow-up in our research study cohort, and so we're now achieving that. We've had some great innovations in recent years, and I really thank all the participants for assistance here. One is the, utilisation of quality of life surveys. So quality of life analysis is more and more becoming a key element to clinical research in cancer. The things that really matter most to my patients that they tell me about is their survival. They want to be cured, but they want good quality of life. So we're now formally recording that. Now, of course, the last 2 years, we've all been living through the consequences of the pandemic. So I'm pretty delighted that we had 11 new projects approved last year during the pandemic. This include use of quality of life data, which is exciting for me. Quite a diverse type of categories of research projects, from clinical, projects that involve our participants and consumers as an important part of research. So that's research that actually, focus on how participants and consumers can add most to the research agenda. 2021, slightly less projects, but still 5 were approved. And I really just want to acknowledge all the researchers that have remained focused and energetic about trying to improve outcomes for patients with melanoma during the pandemic. And you'll notice one other thing I haven't spoken to on those last 2 slides yet is that these projects and the data and the tissue that our participants so generously provide are building the next generation of melanoma researchers through master's courses and also doctorates, PhDs. So thank you so much for enabling the research of those young people. Finally, just to mention that Melanoma Research Victoria is mostly about empowering clinical and other research studies, biomedical studies that look at molecules in melanoma tissue. However, we have branched into a clinical trial funded generously by the Victorian Cancer Agency of putting together 3 drugs for the treatment of BRAF mutant melanoma, the so-called Celebrate trial. And, we're delighted that the Melanoma Research Victoria institutions are all collaborating on this. And that study is well underway at defining initially if you can put those 3 drugs safely together. Okay, so that's my introduction, and now I'll stop sharing my screen, and we'll hand over to the first of our speakers tonight, Dr. Damien Key, on that really fascinating topic of progress in uveal melanoma. And Damien will focus on what has been quite a revolutionary new type of cancer treatment now being applied in uveal melanoma. So Damien, great to have you here this evening, and hand over to you.
Yeah, thank you very much, Grant. I think this is probably the first time we've ever discussed uveal melanomas as part of one of the MRV scientific exchanges. And I'll be covering 2 things. So one, I'll give the audience a very brief primer on uveal melanoma, and then I'll be covering a new therapy that has only recently completed phase 3 trials called Tebentafusp. And then following that, in the second half of the talk, I'll hand over to Mark Shackleton, who will be talking about some of the Victorian initiatives that we're going forward with. Okay, so probably why we haven't really discussed uveal melanoma very much as part of Melanoma Research Victoria is because they are so rare. So to put things in perspective, within Australia, we get about 100 to 150 cases of uveal melanoma a year. And in comparison for cutaneous melanomas, we're looking at closer to 16,000 or probably more. And I guess Tori will probably give us an update on the stats later on. And just like any other type of melanoma, uveal melanoma arises from melanocytes. And in this situation, they arise from the uvea, which, if you look on the diagram on the right-hand side, is this middle layer of the eye that comprises the iris, the ciliary body, which attaches to the lens of the eye, and then this choroid at the back of the eye, which plays a major role in helping to reduce internal reflections and increase visual acuity. So uveal melanomas can arise from any of these structures, but perhaps due to the purely due to the surface area, the majority of these arise in the choroid, so it's 90% of them. The risk factors for uveal melanoma are very similar to cutaneous melanoma, so fair skin, fair hair, fair eye color, lots of nevi, and that's despite the really very distinct biology in the underlying drivers for uveal melanoma. Cutaneous melanomas, as you're well aware, UV radiation plays a big role, but UV radiation plays a very limited role in the pathogenesis of uveal melanomas. Most patients with uveal melanoma will present with some kind of change in their vision, but about a third of patients are going to be asymptomatic, and they'll have something picked up on a routine eye exam for some other cause. So if we look at the underlying genetics from uveal melanoma, they are very distinct from cutaneous melanomas, equilentigious melanomas, and mucosal melanomas. So we are very familiar with looking for BRAF mutations for cutaneous melanomas, and this drives signaling through something called the MAP kinase pathway. So sorry about the acronyms, but in comparison, uveal melanomas don't tend to have MAP kinase pathway alterations. They have a very low tumor mutation burden, which is in contrast to cutaneous melanomas, and they're not associated with UV radiation. The genetics that we do look for in uveal melanoma don't tend to help us predict what treatment we can use, but they have a very strong prognostic role. The mutations, nearly all uveal melanomas will have a mutation in the G-alpha pathway. So that's either GNAQ or GNA11 mutation, and then a subset will have some other mutations in that pathway. And then we get secondary events in something called BAP1 in the splicing pathway, or EAP1AX. And they all have a major role in helping us to work out what the risk of a primary uveal melanoma is in metastasizing. So you can see at the bottom dot point, if you have loss of chromosome 3 or loss of function in BAP1, that's a particularly poor prognostic feature, and you have a fourfold to 20-fold chance of dying of your uveal melanoma. I'll skip this slide for time. Now, in terms of how we treat uveal melanoma, so for local uveal melanoma, how we treat it really is determined by the size and site of the tumor, and we want to try and preserve a patient's vision as much as possible. So for smaller tumors, we either observe them, and they can be very indolent in that behavior, but for slightly larger ones, plaque brachytherapy or particle beam radiotherapy plays a very big role. And there have been a series of trials from this group called the Collaborative Ocular Melanoma Study Group, and they've shown that radiotherapy is equivalent to surgery for medium-sized tumors, and that for larger tumors or tumors where surgery is unavoidable, there's very little benefit from the addition of surgery, of radiotherapy. And just on the diagram on the right, you can see really what they call the radiotherapy plaque, which is essentially a golden disc which has some radiotherapy seeds on the inner surface, and that's stitched by some incredibly skilled surgeons, I imagine, to the outside surface of the eye below the tumor, and it provides a radiation dose to the tumor. Okay, so what about advanced disease? So we know that less than 3% of patients who present with a primary uveal melanoma will have a detectable metastasis or diagnosis, but over the course of their lifetime, they have about half of them will develop metastases, and that very distinctly from cutaneous melanomas, where they tend to spread via the lymphatics. So you get lymph node spread to sentinel nodes and then to other organs. Uveal melanoma, so the eye doesn't really have lymphatic drainage. So the spread of uveal melanomas are via the bloodstream, so hematogenous spread. And 90% of tumors will lodge in the liver. So the liver, lung, bone, and lymph nodes, but the liver is the primary site, and about 2/3 of patients will only develop metastases in the liver. There's a number of prognostic factors, the tumor size, and whether it involves a ciliary body or extends outside of the orbit, and then particular histological features. But as I said before, genetics plays a major role in the prognosis of uveal melanoma. And historically, if you do develop metastatic melanoma, the survival outcomes have been very poor. So about half of patients will progress within 3 months, and the half of patients will live about 1 year or more or less. In terms of treatment, there's been because of its rarity, there's been very few studies that have compared one treatment modality to the other. So it's very hard for us to work out what treatments are the best for metastatic uveal melanoma. Where the metastases are confined just to the liver, sometimes we may opt for liver-directed therapies, and that could be surgical resection of limited tumors, but we can also infuse chemotherapy or other agents directly into the liver, including chemoembolization and radiotherapy beads into the liver. Where patients have more extensive disease, we might need to turn to systemic therapy. And until very recently, we've not had any good comparative data for any of our studies. So we know with chemotherapy, doesn't work very well in cutaneous melanomas, doesn't work in uveal melanomas either, with a response rate of less than 10%. We've tried some targeted therapies which have been very effective for cutaneous melanomas, but MEK inhibitors, which are part of a backbone of cutaneous melanomas, don't seem to translate into an overall survival benefit. And we're investigating things called PKC inhibitors, which work on this GNA alpha pathway, and they're in progress. Unfortunately, because some of those biological features and genetic features of uveal melanoma, with their low tumor mutational burden, and perhaps because they lodge mainly in the liver, which is a very immunotolerant organ, immune checkpoint inhibitors are a lot less effective for uveal melanomas compared to cutaneous melanomas. And drugs such as nivolumab or pembrolizumab or ipilimumab really only benefit, again, less than 10% of patients. We're looking, things with the combination of ipilimumab and nivolumab do look a little bit more active, but again, the proportion of patients who benefit compared to cutaneous melanomas, where about 60% of patients may benefit from the combination, is about a third of that. And the toxicity is very similar, so the risk benefits are much more challenging. And then that brings us to this new exciting treatment called tebentafusp, which is the first treatment that has actually demonstrated an overall survival benefit in uveal melanoma. So I'll just switch to that talk now. So the phase 3 study for tebentafusp was presented earlier this year at a meeting called AACR in April. It was presented, I guess, and we were very privileged to participate in this study at Peter Mac, and you can see one of the authors there, Anthony Joshua, also ran the study at New South Wales, and Michael Brown in Adelaide Hospital. So tebentafusp is a new class of treatment that they call an IMTAC. And what it is, you can see here on the left is this, the darker blue compound is a molecule that binds to a peptide that is expressed by a cell. Okay, so cells can sample peptides within themselves and express them on their surface on this molecule called HLA. And tebentafusp can bind to a peptide on a HLA expressing molecule. So you need to have a specific HLA type, so HLA A0201, that's type of immune molecule that has played a major role in transplantation, but it expresses on the surface of the target cell this molecule GP100, which is a melanoma differentiation marker. And then the other end binds to T cells. So T cells are a main effector cell of the immune system. And by bringing the T cell into proximity to the GP100 expressing uveal melanoma cell, we can get an immune reaction against that tumor cell. And based on an early phase 1/2 study, which you can see on the right-hand side, where patients who received this drug in pre-treated uveal melanoma, so second-line treatment or later, you can see the overall survival plot was certainly very promising compared to the historical control from previous studies, which is shown in yellow. So this was a single-arm study. So based on this data, they went on to perform this 202 study, which is a phase 3 study where untreated patients with uveal melanoma who had this specific HLA type were randomized in a 2-to-1 fashion between tebentafusp or in what might be considered standard of care treatment. So the investigator got to choose, and the majority of investigators chose pembrolizumab, but a small subset received chemotherapy, which is dacarbazine or ipilimumab. And this is the striking finding. So this was the overall survival outcomes for patients receiving tebentafusp versus investigator choice treatment. And the key thing here, you can see that the proportion of patients who were surviving at any one time point was higher for the patients receiving tebentafusp, and that this was associated with roughly a hazard, what we call a hazard ratio of 0.5, so a halving of the risk of dying in any particular time if you were receiving this treatment. What is really interesting about this drug is it doesn't seem to cause tumors to shrink in a reliable fashion. So only 9% of people who receive tebentafusp have an objective response. So that would mean that their tumor has shrunk by about 50% by volume. And that meant that patients didn't have a major improvement in progression-free survival. Okay. But what was really interesting was that even if the patients had progressive disease, so evidence that their tumors were getting larger while receiving tebentafusp treatment, they still seemed to have a better overall survival than if they received the investigator choice arm and had progressive disease. So something different is happening with this drug that is very unusual and not consistent with how we measure benefit from chemotherapies or targeted therapies or even immune checkpoint therapies. Okay, the drug has some unusual particular side effects, and the side effects are related to how it works. So because it activates T cells in a very broad fashion, we get what we call a cytokines mediated adverse events. And this is things like high temperatures, chills and shakes, and you can get low blood pressure, similar to how if you were to go into shock. And that can lead to organ dysfunction. So patients need to have start at a low dose and we up titrate it over time. And then the other is skin related, of course, because GP100 is expressed by normal melanocytes, which reside in the skin, so people can get rash. But the good thing is that very few people had side effects that required them to discontinue treatment. So only 2% of people had to discontinue treatment because of tebentafusp, and that the side effects actually got less with ongoing treatment. So by the 4th or 5th week, these side effects were very much attenuated. Okay, so just to conclude, I get the tebentafusp did show a clinically meaningful improvement in overall survival, and it is the first drug that has demonstrated an overall survival improvement for patients with metastatic melanoma, and that it happens even when you don't have an objective response. So it makes it a little bit hard to know how long we should be treating patients on this drug if they're benefiting, but if their tumor is growing larger, but they're feeling well and apparently their survival is improved. So that will conclude my talk. I might shut down the slides and see if there's any questions.
Thanks very much, Damien. So I think we've only got time for one question, actually maybe we've got a little time for one or two more. But Bruce Robertson has asked Damien, how does melanoma of the choroid relate to the pigmented area or spot on the retina?
Ooh. Okay, so I think that if you look at pictures of the retina, most of the color you will see is probably related to blood vessels, and as well as the optic nerve. So the optic nerve being an area of pallor, and then the other red coloration is due to blood vessels. There is an area called the retinal pigmented epithelium, which is not the same as the choroid layer. And the melanomas of the eye don't tend to originate from the retinal pigmented epithelium, and I do not know why that is the case.
Thanks, Damien. Maybe I'll ask you a question. So you spoke about this interesting molecule HLA, which is important for this new treatment. The Australian Nobel laureate Peter Doherty, here, who works and lives here in Melbourne, made that fundamental discovery about the way that T cells interact with other cells through that HLA molecule. So from a patient's perspective, not every patient can receive the treatment. So, you know, what proportion of people here in Victoria or other parts of the world have this HLA-A2 that means that this treatment could be used?
Yeah, it's a good question, Grant. So the answer is that in the population which is more common for uveal melanoma, so Caucasians, okay, this particular HLA type is present in about 40 to 50% of people. So that means we still haven't got a good treatment, or we still don't have any treatment for the 50 to 60% of people who do not express this HLA type.
Thanks very much. Is there any other questions for Damien before we move on? If no other questions, I think it's thank you very much, Damien. And I did forget to let you know, Damien is head of the melanoma medical oncology service at the Olivia Newton-John Cancer Research and Wellness Centre, and also has a joint appointment at the Peter Mac. Also works at the Hochheiser. So Damien is a real collaborator with across many institutions. Our next speaker will continue the theme of uveal melanoma, and it's a huge pleasure to introduce Professor Mark Shackleton. So Mark is Professor of Cancer Medicine and Head of the Medical Oncology Service at Alfred Hospital and Monash University. And you know, Mark has really contributed enormously to lift the collaborative profile of uveal melanoma here in Victoria. And make linkages elsewhere across the country and the world as well. So Mark, really interested to hear about the latest developments in the way we're trying to tackle uveal melanoma in a multidisciplinary way.
Thank you very much, Grant, and for the opportunity to chat at this great meeting again. It remains a privilege to be part of MRV, and looking forward to supporting the organisation ongoingly to support our local research community, as well as colleagues nationally and internationally through this wonderful vehicle. In fact, I think the kind of experience of MRV over the last decade or so is that, you know, generally when like-minded and sort of similarly intentioned people work together, they are better at getting things done and more productive when working together than if they work in isolation. And this, I think, applies both to routine clinical care contexts, but also to the translational research domain. And I think MRV is a great example of that. And so I wanted to spend a few minutes with you this evening informing this audience as to how that sort of collaboration is increasingly going on behind the scenes, coalesced around the specific subtype of melanoma that we call uveal melanoma, because there have been some really exciting developments in that front, in that behind the scenes collaboration, both regionally here in our state, but also nationally and indeed globally. And it will be great to share some of those developments with you. I've had the privilege to be involved in pretty much all of them, and we're really excited that those behind the scenes collaborations will even further drive along advances in this against this disease, really leveraging and capitalizing on the tremendous breakthroughs that we've had in the last 12 months. So one of the most exciting things I wanted to report is the development of the Victorian Ocular Melanoma Multidisciplinary Meeting, which is a collaboration between 4 institutes indicated across the bottom of the slide there. The Royal Victorian Eye and Ear Hospital, Peter Mac, the Austin Hospital, and the Alfred Hospital. So about, it must be 30 or more years ago now, the kind of notion of multidisciplinary fora towards improving patient management with a whole range of different diseases, particularly cancer, was developed. And in Victoria, some of the earliest multidisciplinary meetings were in fact developed in that sort of early 1990s period, including in melanoma at the Victorian Melanoma Service at the Alfred back then, but also around other diseases. I think the breast cancer multidisciplinary meeting at Peter Mac was also one of the first ones. MDMs, as we call them, are essentially fora in which clinicians and sometimes researchers and certainly nursing practitioners and allied health experts essentially get together in the same room to provide input and lend their experience and expertise towards making management decisions for individual patients. So in the case of cutaneous melanoma, so skin melanoma, the treatment of patients or management of patients via MDM discussions is pretty much routine in most parts of the world, certainly most major centres. And there are several cutaneous melanoma MDMs that occur across Victoria, typically attended by dermatologists, surgeons, radiation specialists, medical oncologists, nurses, allied health practitioners, researchers, et cetera, et cetera, et cetera. And these are really the key vehicles through which expert decision-making around the management of individual patients is developed and applied. We haven't had one of these types of fora in ocular melanoma before, which is, I guess, maybe a little surprising to some, but probably relates to the fact that until very recently, as Damien's alluded to, the treatment options have actually been relatively limited. However, with the exciting advances now coming to the fore in systemic therapy and the really impressive developments in the basic and translational research sector in uveal melanoma, a group of colleagues around town have felt the need, and specifically driven by the ophthalmologists at the Eye and Ear Hospital, who are really the group that sees all patients, usually as the first port of call, has now seen the need to create our own Victorian ocular melanoma MDM. And this was, and so I want to, I guess, have a major shout out here to Dr. John McKenzie, the head of the Ocular Melanoma Service at the Eye and Ear Hospital, for providing tremendous leadership in putting this together, and in fact in actually hosting the meeting and providing resources from within the Eye and Ear Hospital to support the administration around the meeting. So John and others, we sort of talked about having this meeting probably for about 6 months or so, and it took us a while to get the resources together. But I'm really excited to report that one of the major developments in this field locally in 2021 has been the commencement of these meetings as a regular part of our calendars. So at the moment, we're meeting about once a month, once every 4 weeks or so, on a Wednesday lunchtime. And essentially all of the patients that present to the Eye and Ear Hospital service, as well as the other dedicated cancer treatment services listed there, present and discuss individual cases. And already I think it's providing a very fertile ground for innovation, not only in specific treatment, but also illuminating many many different types of research opportunities that exist. Many of which, in fact, begin with developing and supporting processes around data and tissue collection. And so it's great to have Melanoma Research Victoria as a key partner in those processes. Albeit that MRV, not having worked with ophthalmologists and eye specialists before, we'll need to think about the ways in which we adapt our data, adapt and indeed augment our data collection processes to be able to support the data collection needs of ophthalmologists, which are a little bit different because it's such a highly specialised area of medical practice. Anyway, the Victorian Ocular Melanoma MDM is up and running, and we're looking forward to that vehicle supporting these patients going forward. Thinking now more nationally and indeed internationally, I wanted to draw attention to major developments and attention indeed in uveal melanoma that's come from our National Cooperative Clinical Trials Group in melanoma and skin cancer. And that's a group which is called Melanoma and Skin Cancer Trials, or MASK Trials. So this group was previously known as ANZMTG, or the Australian New Zealand Melanoma Trials Group, and a few years ago became incorporated and also sought to broaden its operations to include not just cutaneous melanoma, but other types of melanoma, and indeed accommodate all types of skin cancer. As a cooperative clinical trials group supported by Cancer Australia, so by the federal government, we have a major imperative to support, lead and design new research proposals and to assist investigators to get funding for those research proposals, particularly including clinical trials, by applications to NHMRC and other government sources, sometimes philanthropy, sometimes even the pharmaceutical industry, depending on the study. So that's really the major role of the group. We also seek to support project management for studies that have received funding and the ability to do this across national as well as international networks. The group also provides access through our affiliation nowadays with Monash University, as well as our support from Cancer Australia to all the resources and facilities that those entities provide, extensive resources in clinical trial development through the uni, access to a wonderful group of very committed consumers. In fact, many of whom I will say also have very strong links to Melanoma Research Victoria, and also fantastic technical services to support quality of life and economic research provided through the Cancer Australia Technical Services Scheme. The main vehicles through which MASK Trials research is developed are these vehicles which are called discipline-specific advisory committees, and we have committees that sit across all of the main areas. There's a few different committees that are relevant to cutaneous melanoma, and these are the current chairs of these committees here. But we also have some priority-specific research areas or special interest research areas. One in keratinocyte cancer and one in Merkel cell cancer. But most relevant to this talk, of course, is the discipline-specific advisory group, which is called AOMA, or the Australian Ocular Melanoma Alliance. So we actually established this group probably 2 or 3 years ago now, and it's really been a tremendous initiative within the group that is very rapidly gaining momentum and now starting to develop and oversee the first bona fide research projects. It's a group that brings together clinicians and scientists and patient advocates that have never really kind of collaborated before, and so has, I think, provided a great vehicle for such collaboration. The group is currently chaired by Professor Anthony Joshua, a medical oncologist from St Vincent's Hospital in Sydney, as well as Dr. Leanne Lim, an ophthalmologist also from Sydney. But and it's, as I said, providing a tremendous group through which ophthalmologists, who are, as I said, the key kind of gatekeepers of this disease in terms of the first ports of call for the vast majority of patients, whereby those doctors can start to interact with some of the other key other groups, both clinical as well as research, who are relevant to this disease across the country. And so MAST Trials provides the administrative support to, if you like, herd these cats and get them together to talk about the important research priorities. And there have been several that have been identified so far. This slide describes some of those efforts, major imperatives around developing therapies that maximize for early stage disease, that maximize the preservation of vision, which is often a massive issue for patients affected and who need treatment for early stage uveal melanoma. But now increasingly moving into the field of effective systemic therapies and how these might be applied both in adjuvant settings as well as in patients that unfortunately develop metastatic disease. So just the formation of this group alone has started to really hone in on what we think are the key research questions in this field going forward. And so the actual research projects that are currently overseen and have been developed and overseen by the group particularly include the Uveal Melanoma Registry, which I'll mention more of in a moment. The CIA is Anthony, and this is the first project that we've had endorsed by the group and enabled an Australian contribution to a much larger global project. The group has developed some really innovative research projects, particularly around using circulating markers in the bloodstream, such as circulating DNA, to monitor and evaluate patients with the disease, and also some research projects specifically around improving the way that systemic therapies are administered to patients with metastatic uveal melanoma. Unfortunately, we haven't actually got funding for those latter projects yet, but these are actually really nice studies that, with further development and continued submissions, I'm very confident will get studied, will get funded. There are some also active projects going on in the really interesting neoadjuvant and adjuvant space, with particular focus at the moment on a study which the group has endorsed, which seeks to test the utility of protein kinase C inhibitors in managing early stage patients with uveal melanoma. And the final sort of really exciting project has been the acquisition of funding to support a national uveal melanoma nurse position, which is actually based in Sydney, but is a fantastic resource nationally for patients, and the access to this person is really quite easy these days now that so many have switched to tele-type communications. The other thing the group's done is to kind of boost enthusiasm and activity around the disease, is to actually host 2 meetings. We had the first 2 national meetings at which we've had fantastic international speakers. The first was in 2019. The second had to be cancelled last year because of COVID, but we managed to get the second meeting off the ground despite ongoing COVID issues earlier on in 2021. So the AOMA group is, I think, really doing a fantastic job in bringing together disparate or previously disparate clinicians and researchers with an interest in this disease, putting them together in groups and encouraging them to come up with innovative solutions to improve the outcomes for patients. And some of the other projects that they've got in mind at the moment, including a guidelines development project, practice pattern surveys, and establishing national research resources for uveal melanoma, are all well and truly on the table. And this is just a slide that highlights the efforts by the group to engage and now actually contribute data to OMNI, which is the International Ocular Melanoma Natural History Study, based in New York, in the US, but receiving data really from all over the world. I think a very, very exciting project, anticipated many, many hundreds of patients are going to be donating their clinical information into this study, and this will provide an incredibly valuable resource to support research against in uveal melanoma going forward for many, many years in the future. So with that, I'll leave that there, Grant, and stop sharing, and happy to take questions about some of the behind the scenes things that we're working on at the moment.
Fantastic. Thanks, Mark. And look, and congratulations to everyone involved. I mean, in a rare cancer like uveal melanoma, national and international approaches, are the way to really speed up progress. So I think it's incredibly exciting. Any questions, please type them into Q&A or chat. And Mark, maybe I might just ask you about the multidisciplinary meeting. So, what used to happen? Why is this now making, do you think, a big difference to patients? And what's the difference to what used to happen before John Mackenzie and yourself established this group?
Yeah, I think as for the experience in many other cancers, I mean, many kind of medical specialists, kind of grow up in and substantially work in their own silos, and that's sort of the way we, used to. I mean, when I was taught oncology, that was kind of the way that was sort of the way that it went. But it became pretty obvious, particularly with therapy innovations across multiple disciplines, that the ability to work out ways creatively to combine therapies that required the input of different specialists actually further improved outcomes beyond the sort of siloed sort of single specialty approach. So if you've got sort of evidence that combining things like radiation with other treatment modalities work, then you actually need to create fora in which that radiation specialist and the other doctor can actually work together and figure out what is the best approach for an individual patient. So I think that it's a really proven approach and proven formula in multiple other tumor streams. And sort of as I said at the start, I think uveal melanoma has been kind of waiting for therapy innovation in other areas other than ophthalmology, other than by the eye doctors. And I think now we've got real innovations coming through in the ability to deliver even external radiation in very, very focused ways. And now this kind of wave of systemic or drug-based therapy innovation that's starting to come through, that it's sort of a no-brainer that really now is the time that the different medical craft groups that oversee those different types of treatments really need to get together and to work out the ways in which these different treatments can be integrated and combined to improve patient outcomes.
Yeah, thanks, Shaq. There's a question has come through, and we don't get into the nuances of people's individual cases, as a medical consultation is the best way of dealing with that. But Mark, what do you think is the best way for someone that has a they say they go to an optician, and the optician finds a pigmented spot on the back of their eye? What do you think the best way of getting that followed up and investigated?
Yeah, so I think that the referral path is reasonably straightforward. That is, and I mean, and there are many pigmented spots that form behind the eye that are not uveal melanoma. So just because an eye specialist finds a spot does not mean that it's a melanoma. But the referral pathway is reasonably standard. I mean, if you go and have an eye checkup and you get your vision tested and the optometrist looks behind the eye and sees something, then you really do need to see an eye specialist or an ophthalmologist as part of routine follow-up from that. I think optometrists can actually refer directly to ophthalmologists. You actually don't have to go via your GP, but the alternative path would, of course, be to go to your GP and to get a referral to an ophthalmologist. And it actually doesn't have to be a uveal melanoma specialist at that particular point in time.
Mm-hmm.
If you just go and see a general ophthalmologist, they will have more than adequate capability to do the initial sort of screening, figure out whether this is likely to be some sort of benign process that you don't need to worry about too much, or maybe there are some features about the spot that are a little bit concerning, in which case that ophthalmologist would usually ongoingly refer you to a more highly specialized context, such as at the Eye and Ear Hospital, which is really the main node for specific treatment of uveal melanoma in this part of Australia.
Great, thanks very much, Mark. That's very, very clear. Okay, well, thank you to Damien and Mark. I feel there's real momentum in this disease, and it's just evolving so well throughout my career. And I think the future, is looking a lot more optimistic for uveal melanoma. This evening to be joined by my colleague Victoria Ma, who is head of the Victorian Melanoma Service at Alfred Health and an associate professor at Monash University. So, melanoma in Victoria. Victoria, how are we doing?
Thanks, Grant. And thanks, Alison. That was a great run through of the findings of the State of the Nation. And I think everyone's really interested to see that report when it comes out in February. So from State of the Nation to State of Victoria, we're going to look at how we've been faring through what has been a few difficult years, particularly with lockdowns and so on in this state and particularly affected in Melbourne, but also our regional patients, I think, have certainly been affected by difficulties accessing hospital care and so on as well. So we're certainly familiar with these guys on the screen at the moment, and I think we've sort of used to seeing these graphs of an incidence in melanoma increasing with fairly stable mortality. And you can see here that the incidence in both invasive disease and in situ disease has been increasing in different populations, not just Australia. And this is a paper that was published early this year in the New England Journal, so one of the top medical journals. And it was really looking at the way we diagnose melanoma and if we're doing the right thing and if we're potentially over-screening patients, leading to a sort of falsely elevated incidence of melanoma. And so it caused quite a lot of discussion amongst our colleagues, and people weren't necessarily particularly happy with the messages that were coming through from this paper. But it is sort of cause to, I think, reflect and look at this issue more broadly, and also think about how the COVID pandemic may affect the ways in which we detect melanoma during sort of shutdown periods, and whether that's had necessarily an adverse effect. So we have the melanoma increase in incidence and the COVID pandemic, and is there a real actual melanoma pandemic in the end? Are we actually sort of making a lot of overdiagnoses? There have been a number of concerns about screening for some time and potential harms, one of them being overdiagnosis. So overdiagnosis is really not the same as misdiagnosis. So overdiagnosis relates to disease that if it was left on the skin, it really wouldn't cause any harm if it was left undiscovered in that person's lifetime. And that's a little bit different to another phenomenon that we recognise called essentially diagnostic drift, whereby some tumours that might have been called benign 20 years ago might be reevaluated these days under certain criteria and end up stage 2 to melanoma. So this paper looked at those phenomena and showed the number of people undergoing skin biopsies, and showed that really we're seeing the doctor more and more for skin biopsies and skin examinations. You can see that's in the graph on the left there. And then there's this phenomenon of diagnostic drift shown in the bar graph on the right. And this was sort of an experiment where pathologists were shown the same slides from 20 years ago, and there was an evaluation to see how frequently they changed their opinion, and mostly there was no change, but some of them certainly did upgrade the lesion to melanoma, and just a few of them were downgraded to a benign lesion, which is kind of interesting. So highlights this issue of possible diagnostic drift. Katie Bell and colleagues in Sydney published this paper recently in March last year that just looked at the issue of overdiagnosis in cancer in general, but melanoma certainly fell out as one cancer type where this might be an issue. And in her paper, she estimated that potentially 54% of melanomas in women and 58% in men were potentially overdiagnosed. So that is, if they were left undiscovered, they wouldn't have caused harm in that person's lifetime. And certainly screening has other issues, and we can see patients who have lots and lots of biopsies just in case. And this can certainly cause, apart from the scarring, sort of a snowballing effect in terms of anxiety and what to expect. So this New England Journal paper really asks this question: well, should we really be stopping screening skin examinations to just slow down this increase in the rate of melanoma diagnosis and potential overdiagnosis? And so they made the sort of statement that perhaps the COVID pandemic might be a good thing and might show us that in fact we can stop screening, and that would be a safe approach. So we'll look at what's happened during the COVID pandemic in the next few slides, at least in Victoria. So 2019, pre-COVID, we saw close to 3,000 invasive cases, and in fact over that period we would have expected about 5,000 in situ cases. And you can see there the breakdown of stage just of the invasive cases, and by far and away the most common stage is stage 1, early melanoma, with an excellent prognosis. This paper was published by the cancer people from the Cancer Registry, as well as Grant and others on this paper, and looked at the estimated number of tumours that went undiagnosed during the lockdown period in 2020. And melanoma certainly came out as one tumour subtype that was of concern, with just over 500 cases estimated to be undiagnosed during that period. So we looked at this at our own centre, and this is data obviously from the tertiary centre, and I think the caveat is that perhaps there were people that were avoiding coming into hospital over that period last year and were tending to be treated more so in the community. But we looked at the COVID impact on follow-up of our patients who had had a diagnosis the year before and were needing to attend their usual doctor for follow-up. And we did this by phone interview of about 80 or 90 patients. And there were about 20 out of that group who did report a delay over that period of time in their follow-up care due to COVID. And we did see a significant drop-off in our referrals for management of melanoma over that period as well. You can see there in the top bar graph, that was our referrals that dropped off over that period. And then in the middle graphs, you can see that the 2017 to 2019 period there in the black columns, and the grey columns is the 2020 year, and you can see that the in situ and T1 tumour stages certainly had a very significant drop-off, whereas there wasn't such a significant drop-off for people presenting with thicker tumours over that period. So really, there has been certainly a reduction in melanoma diagnoses during the pandemic, and it really has tended to be those in situ and stage 1 tumours that we've seen drop off. At this stage, there doesn't seem to be a surge or a rebound in diagnoses yet, but I think it will be really interesting in the future to look out for this phenomenon of a stage shift. And I think over the next year or two, it will be really interesting to have a look at that and then go back to that New England Journal paper just to understand a little bit more what that COVID impact might have been on the way we screen and the implications of that going forward, because certainly we want to be seeing patients at an early stage in order to prevent them getting more concerning disease down the track. But certainly at the same time, we do want to avoid this phenomenon of overdiagnosis, and we don't want to be contributing to the overall burden of disease for patients and in fact for the health system. So thank you, and I would be happy to take any questions.
Fantastic. Thanks. Thanks very much, Tori. It's a pretty provocative sort of idea, right? I mean, we think that all cancers are bad, and we should be removing as many as possible at the earliest stage possible. So I guess we do have like a natural experiment happening, don't we, with the impact of COVID, and it's probably even greater, at least in other cancers overseas. So, you know, worldwide data is going to be, I think, going to be very interesting. Now, there is one question around melanomas in women and men. Did they distinguish between new patients and existing melanoma patients who may have had further, a second or more melanomas? So thanks. Another good question from Bruce.
Yeah, this is from the cancer registry data. I think you're talking, Bruce. This was, I think the data is new presentations, but I'd have to confirm that actually, new presentations of new primary disease. And then there was certainly a handful of stage 4 diagnoses during that time period as well. So they would have been people who'd presented with recurrent or progressed disease. But yeah, the main thing that we tended to see was a reduction in those new cases.
Right, another superb question that I love has come through. Is it better for patient outcomes to overdiagnose than underdiagnose? Great question.
Yeah, look, it's a really good question, I think, and I think it's a real balance, isn't it? Because I think there are some melanomas that will be quite indolent in their biology and won't cause harm, and there are others that will be thin and nevertheless they will metastasize, and it's impossible at this point to know which will behave poorly. So I think at this stage there, it is probably safer to certainly be removing all of those tumours that we're worried about. And in time, I hope that we will have better predictive sort of features that we'll be able to assess which ones might in fact be able to be left and not do harm. But at this stage we don't. So I think we've got to revert to cutting out if we're concerned.
Okay, we might just do one more question, which is from Mark. How did the authors of the New England Journal of Medicine paper know if a melanoma will not be harmful in the future?
No, I don't think they did, Mark, in that paper. It was just sort of hypothesising that perhaps, we are overdiagnosing more tumours and that there's been this, rapid increase in incidence and the mortality has sort of stayed the same, and particularly that rapid increase in situ disease. So we're just screening more, finding more, but a good proportion of those are sort of essentially tumours that would never do anything harmful because there's no, increase in, because the mortality figures sort of reflect that.
Great. Thanks very much, Tori. So we do need to move on because we're running a little behind, and we'll now move into a very special part of the annual scientific exchange agenda, which is the award and the scientific presentations for the Morgan Mansell Award. And I'll hand over to my colleague, Professor Mark Shackleton, who you heard from earlier, who will chair this particularly important part of tonight's agenda. Over to you, Mark.
Thanks very much, Grant. It's a real honour to again present the finalists of the for the 2021 Morgan Mansell Award. So, by way of brief background, it's a great privilege to be a doctor and to get to work with and care for people and their families going through often an incredibly difficult experience with serious and often life-threatening illness. And it was certainly my real privilege to be involved in the care of Morgan, who was a young lady in her 20s, affected and unfortunately who eventually died from melanoma. She was a really remarkable young lady, probably the most medically complex patient I've ever actually cared for, in terms of the weight of challenging medical issues that she faced, even actually before she got melanoma, but then particularly after she developed it. But in spite of everything that she went through, and also that her parents, Peter and Julie, went through, she just had this remarkable ability to kind of see, I guess, the big picture, and to be very kind of outward looking, and acknowledging the experience of other people similarly affected by this disease. And so in the last sort of period of her life, actually put quite a lot of effort into developing community awareness programs and around melanoma. So there's in January on her birthday, there's now a Check for Spots Day, which was really the sort of brainchild of Mansell and then her parents. But the other thing that she was really keen to support was also to acknowledge the efforts and contributions of researchers who are working away in hospitals and in laboratories, trying to come up with better and improved treatments for this disease. And so after Morgan passed away, her parents decided to make a donation to the melanoma research community of Victoria to be spent in making an award to the most outstanding contribution to melanoma research by a Victorian or done at a Victorian institute within the last couple of years. So this is the third, I think, year that we've held this award. The two previous winners and indeed all the finalists have really demonstrated the very high level of a high caliber of research that's going on in this part of the world. And so it's my real pleasure to introduce to you the current finalists, or to the 2021 finalists for the Morgan Mansell Award, and to introduce them. So each finalist is going to give a brief presentation of their research, and then after the presentations, I'll announce the winner, and then somehow virtually we'll have to figure out how to get the award to the actual winner, but that will happen behind the scenes. So without further ado, you don't want to hear from me anymore. You want to hear from the actual people doing the work. It's my pleasure to introduce the first of the finalists, Dr. Sophie Lim. So Sophie, can you jump up on the screen? I'll get out of your way and go for it. Thanks, Sophie.
Thank you, Prof Shackleton, for the introduction. And hello, everyone. My name is Sophie Lim, and I am currently a junior doctor working at Alfred Health. Today, I will present to you a brief overview of my melanoma project titled Evaluation of Clonality in Lentigo Maligna. Lentigo maligna, or LM, is a non-invasive in situ melanoma that arises due to cumulative sun damage. It thus often occurs on the head and neck of patients, as you can see in these images here, and it usually affects patients over the age of 40. Although LMs are not aggressive cancers, we treat them because they have a risk of developing into deeper invasive lentigo maligna melanomas, or LMMs. Lentigo malignas have a high rate of local recurrence, and the reason behind this has never been formally explored. Understanding the mechanism of local recurrence in LMs has direct implications on patient management. It could be that the original incident LM is excised, but there is microscopic residual disease that gives rise to the local recurrence. If this is the case, then the incident and recurrent LMs would be biologically or clonally related, and complete excision of LMs with adequate margins should theoretically prevent local recurrence. Alternatively, it could be that the incident LM is indeed fully excised, and the apparently recurrent LM is in fact a new primary growing in that adjacent area, in that macroscopically similar area, all affected by sun damage. This concept is known as field cancerization, and if this is the reason behind local recurrence, then the incident and recurrent LMs would be clonally unrelated. In such instances, we could potentially prevent local recurrence by not only excising the LMs, but also treating their high-risk surrounding areas with topical creams in order to eradicate any precancerous cells that can later give rise to more LMs. So, in order to understand that mechanism of local recurrence in LMs, our primary aim was to assess the clonal relationship between lentigo maligna and its local recurrence. To do this, we recruited 7 patients with LMs that recurred as, again, LMs, as well as 4 patients with LMs that recurred with an extra invasive component, i.e. as LMMs. We took the tissue samples collected during surgery, then laser microdissected the tumor components, as you can see in that bottom image there. And this was done in order to optimize the purity of the DNA that we extracted. Once we extracted the DNA, we sequenced it, then analyzed it using specialized bioinformatics tools. Now, before I move on to present to you our main results, I would firstly like to explain to you how to interpret them. So these figures here represent the relationship between the mutational profiles of different LMs. Each of these lines represent a mutation, and the leftmost bar here represents, in terms of different colors, the different groups of mutations. So we can see that in the 2 parts of a single LM, the red and the blue group of mutations are present in both. This demonstrates that these 2 parts are indeed biologically or clonally related. On the other hand, we can see that in the 2 separate LMs on a single patient, only the red group of mutations is present in one, and the blue group of mutations is present in the other, showing that they are indeed clonally unrelated. Now, when we observe the figures of our 11 cases of LMs that have locally recurred, we can see that they roughly resemble the figure with the 2 parts of a single LM. There's at least one group of mutations present in the incident LMs that reappear in their postoperative local recurrences. There is an extra column for the LMM recurrences because we have divided up the in situ and invasive components. So essentially, these figures demonstrate to us that all 11 incident LMs were clonally related to their postoperative local recurrences. This conclusion strongly suggests that local recurrence is due to residual disease and not field cancerization, and therefore clinicians should continue to strive to fully excise LMs with sufficient margins in order to prevent local recurrence. Thank you.
Great, thanks very much, Sophie. It's a fantastic study. It's been a real privilege to be involved in it, you know, kudos to you and particularly P. Mansell for driving along that work. So we haven't really got time for questions, and so I'm just going to move through and take pleasure in introducing our second finalist for the Morgan Mansell Prize, Zhen Yu. So Zhen, could you load yourself up?
Yeah, hi. Yeah, let me share my screen.
Yeah, we just need to get you to turn on your video if that's all right as well.
Okay, yeah. So.
Great, thanks. Take it away.
Sorry. Okay, is this correct, right? Yeah, hello everyone, my name is Zhen and I'm a second year PhD student at Center Clinical School. So I'm very glad to be here for sharing my research work. And today I will give a brief introduction of my research project about melanoma diagnosis with AI algorithm. So we all
Zhen,
know.
before you start, sorry, we can't see your slides.
Oh, sorry.
That's okay. I think you unshared by accident.
Okay, let me have a change. Okay, it's correct, right?
Yep.
Okay, yeah. So, we all know melanoma is Australia's national cancer. So, clinically, melanoma was diagnosed by visual demoscopic examination. That is, clinicians will visually assess the morphological feature of lesions like color, shape, and texture. Recent years, artificial intelligence algorithms have demonstrated remarkable performance in dermatology. Deep learning-based techniques are the most promising and have achieved performance at least equivalent to that of experienced clinicians in imagery-based diagnosis under experimental conditions. So, deep learning model is a kind of data-driven AI algorithm. That is, this kind of model can automatically learn image features from image data, which is labeled by a human, and then perform classification by giving disease probability of a lesion being malignancy. So although this model gives very powerful performance for malignant melanoma diagnosis, most of them will directly train with image data without considering the clinical situation. For example, a typical lesion may exhibit overlapped symptom with malignant melanoma. So in this case, we may need additional clues for diagnosing those ambiguous lesions. So this drives us to explore using clinical diagnostic strategy to develop AI algorithms and improve performance of melanoma diagnosis. So this covers our research topic, that is clinical inspired AI image analysis for melanoma diagnosis. Our first project is to incorporate information of lesion evolution into AI models and train algorithms with sequential demoscopic images for early melanoma diagnosis, because usually benign lesion will stay fairly stable across time, while melanoma will progressively change over time. In this study, our aim is to verify if modeling lesion changes with several demoscopic images can achieve early and accurate diagnosis than clinicians. So we here performed a retrospective view of histology report from private clinical between 2007 and 2019. We compared diagnostic result between our algorithm and 12 clinicians from Africa. The result was based on 89 melanoma and 90 benign lesions during total body photography and CDI monitoring. Here is a simple result, brief result. Our model achieved an ICC of 63%, the sensitivity of 60, and specificity of around 66. And by contrast, dermatologists have achieved a range ICC of 54% and sensitivity of 62, and a specificity of 46%. So AI model has better accuracy and specificity, which means less false positivity, false positively on this dataset. Also, the AI model correctly diagnosed 60% of melanoma at first image for the dermoscopic image sequence, which is higher than that of 32% by clinicians. So, both of these results shows modeling temporal lesion changes could help AI obtain early and more accurate performance, and AI could be promising tools in distinguishing melanostic nevi from melanoma in patients undergoing TPP and SCGI. So another project is based on modeling active darkening sign for melanoma diagnosis. Active darkening sign is also a kind of diagnostic strategy in clinical, which suggests comparing a group of lesions from same patient to find the outlier lesions, because melanoma tend to stand out like active darkening. So in this study, we construct an AI model on public skin dataset, which consists of 30,000 dermoscopic images from 2,000 patients. For our model, we present a group of lesions to recognize darkening sign and predict the probability of lesion being malignancy. Additionally, we train a baseline algorithm, which is trained without using the darkening contact for comparison. Five-fold cross-validation was performed on the data from those 2,000 patients, and we can see the result. AI model trained without darkening sign achieved AUC around 83%, and AI model with darkening sign achieved AUC of 86%. So there are almost 3% improvement in accuracy AUC. So this study demonstrates the ability of incorporating darkening sign in AI models for melanoma diagnosis. Both of this study were published in this year. So for more details, if you are interested, you can refer to those papers. Our future work, we will explore larger seeking data for learning and improve our AI algorithms. Also, we intend to conduct clinical trials to validate the performance of our AI algorithm in real clinical setting. Finally, our project also actually was part of SMIT, and we'd like to thank all professors and dermatologists for joining those researchers, and they paid lots of time for evaluating lesions and for discussing the result. Yeah, so that's all for my part. Thank you.
Thanks very much, Zhen. It's a super exciting and highly innovative space, and it's great to see MRV affiliated researchers really leading the way internationally in this super important area that actually has a lot of implications for that issue around metro versus regional disparity in the way that we care for melanoma and skin cancer patients. So congratulations on fantastic work. We'll now move to if you could just stop sharing your slides, and that's great, and turn your video off. Yeah. And we'll now move to our next speaker, our next finalist for the prize, Dr. Mabel Yan. Over to you, Mabel. Take it away.
You're on mute, Mabel.
You're on, yep.
Yes, thank you. I'm sorry. Hi, everyone. Thank you very much for inviting me to present here today. I'll be giving a brief overview of my work that I'm doing as part of the PhD. So we know that advanced melanoma is associated with poorer outcomes. So being able to explore strategies to prevent melanoma from developing is really important. Preventive strategies to date have largely focused on promoting sun protective behavior because we know that UV radiation from the sun is a major risk factor for melanoma development. Aspirin is a really commonly used medication with both blood thinning and also anti-inflammatory properties, and it's frequently prescribed after people have a stroke or heart attack. Studies have suggested that aspirin might reduce the risk of some cancers, and the evidence is strongest for its possible preventive effect against bowel cancer. However, the association between aspirin and melanoma is not clear, and therefore I sought to explore this question using data from a large trial of aspirin called ASPRI. Aspirin included patients from Australia and the United States, and it randomly allocated over 19,000 participants to either once daily aspirin or matched placebo. The trial phase ended after 4.7 years average follow-up time, and then participants were invited to participate into an observational study. So most recently, I obtained data with an average follow-up time of 6.3 years. And in this analysis, we did find a lower number of melanoma events that occurred inside the aspirin arm compared to the placebo arm. And in this figure on the right, the dotted line represents the aspirin group and the solid line is the placebo group, and there is a lower number of events shown. However, this result was not statistically significant. We did find an interesting observation in that individuals with poorly controlled blood pressure randomized to aspirin appeared to have a lower number of melanoma events. However, this was not seen inside the patients with normal blood pressure. So overall, we didn't find a clear preventive effect of aspirin against melanoma. However, given that studies looking at aspirin and bowel cancer, which is the area of research that's a bit more progressed, those studies have not found an effect of aspirin until up to 5 to 10 years. So ongoing follow-up of this cohort would be important to allow us to assess whether there might be a possible delayed effect of aspirin against melanoma. And also considering that we know aspirin has proven heart protective benefits, exploring aspirin's possible preventive role against melanoma would be important, because maybe future studies might find that aspirin has a particular benefit amongst subgroups of patients who might have risk factors for both heart conditions and also melanoma. I was also going to touch on another study that I mentioned in my application that I'm also undertaking. And this study is looking at the utility of routine imaging for the follow-up of patients. So we know that melanoma recurrence can occur in unpredictable ways, and we usually do perform regular body and brain scans to monitor whether the disease might be coming back. But imaging also has its risks, including exposure to radiation, and it can also lead to unnecessary anxiety and also unnecessary procedures for our patients. And it's actually not very clear from the underlying evidence base how frequently these scans should be done, how the time frame between the scans, and also the timing of the diagnosis trajectory at which they should be performed. So I'm looking at this question using data from the Victorian Melanoma Service database. And in the first part of my analysis that I presented the findings as a poster, I found that routine imaging at first diagnosis for patients with high-risk tumors, so thick and ulcerated tumors, and is of low yield for detecting distantly spread disease if the patient's sentinel lymph node biopsy is negative. So thank you very much for listening. And also I wanted to say a big thank you to my supervisors for inspiring me to do this research.
Thanks very much, Mabel. That was great. Really interesting. I mean, the ASPRI study is really a remarkable resource, and so many interesting and surprising insights. So I'll be very keen to, I mean, the whole question of melanoma prevention is such a critical one. And I mean, I agree, you're probably right. We need to be looking more at high risk populations rather than sort of more general populations. But you know, this is very important data that I think will inform future research in that area. And then the work on scans that you didn't show in detail, but it's also really critical, because we're really not sure what the best way to follow up patients is after treatment with imaging, or even to sort of assess them around the time of first diagnosis, particularly of the poorer prognosis tumours. So this is this is really important work that ultimately helps us to manage patients better. Great. So thanks, Mabel. We'll just get you to dial out of your video, and we'll move on to the last of the finalists, Katharina Hochheiser. Where's Katharina? There she is. Thanks very much, Katharina. Over to you.
Thank you very much for inviting me to present my data here. So I'm a postdoc and I work together with Thomas Geppert and David Bjorky. And our goal is to understand immune control in metastatic melanoma. And to this end, we have developed a novel preclinical model. So we transplant B16 melanoma cells onto the outermost layer of mouse skin. And then 2 weeks after inoculations, we remove the site of the primary tumor or the inoculation site by curative intent surgery. And by using B16 cells that express the enzyme luciferase, we are then able to track metastasis development via weekly IVUS imaging. And as you can see in these images here, some of the mice will develop spontaneous metastases in the draining lymph nodes. So these are those IVUS images, and next to those images, you can see the lymph node which have those black deposits. So we can track metastasis development and growth over time. And in this graph here, you can see the radiance, which is the quantified bioluminescent signal for individual mice. So each line here is one individual mouse. And as you can see, some of these mice will develop metastases quite early on, whereas others seem to control disease for a very long time, and metastases will only appear or grow out after 8 weeks. And some mice will actually never develop any metastatic disease, which means that the surgery has actually cured these mice. On average, we see metastasis outgrowth in roughly 22% of mice, although as you can see, this varies a bit in between experiments. And we know that the characteristics of the primary tumor, so the radiance or the size of the primary tumor at the time of surgery, influences the outcome. So mice that have a big primary tumor will be more likely to develop metastatic disease compared to mice with a very, very low signal or very small primary tumor. However, you can also see that there are exceptions. So some mice with a very big primary tumor will actually never develop metastatic disease. And we know that this is due to immune control, because mice that lack the adaptive arm of the immune system, so B and T cells, or mice that are broadly immunodeficient will develop metastases at a much higher rate. And those metastases also develop quite rapidly, so we don't see those long-term controllers. And one other feature of our model is that metastases are not necessarily confined to the draining lymph nodes, but in some cases, they also spread to visceral organs. And this happens in roughly 25% of all control or wild type mice with metastases in their draining lymph nodes. And the frequency is a bit higher in mice lacking B and T cells, and is at 100% in mice that are broadly immunodeficient. So here we can actually see those melanoma deposits in various visceral organs. So this shows that our model recapitulates clinical outcomes ranging from complete immune control to metastatic melanoma with the involvement of several organs. So the development of metastasis is actually a multi-step process, and we wanted to address the role of two types of immune cells, so-called NK or natural killer cells, and CD8 T cells in different steps of this process. So one step is the metastatic seeding or the dissemination to distant sites, and one step is actually the local control or the prevention of the outgrowth. So in order to address the roles of those two cell types, which are known to be important for cancer control, we depleted those cells either early on at the time of inoculation to address whether they played a role in metastatic seeding, or we depleted them once we had removed the primary tumor. So once the source of the cells that could metastasize was removed. And what we found was that when we when we depleted those NK cells, mice were much more susceptible towards metastasis development. But that was only the case when we took away the NK cells very early on, so at the time of inoculation. That did not play a role at local immune control. So when we depleted them later, there wasn't any difference compared to control mice. The picture looked quite different for CD8 T cells. So no matter if we depleted them early during our experimental setup or after removal of the primary tumor, mice depleted of those CD8 T cells were actually much more susceptible to metastatic disease. So this shows that there is actually a division of labor between those NK cells and CD8 T cells in preventing metastatic disease, while NK cells and potentially also T cells and other lymphocytes control the seeding of metastases to distant sites. CD8 T cells are crucial in preventing metastatic outgrowth. And with this, I would like to thank you for your attention and everyone involved in this project.
Thanks so much, Katharina. That's super interesting work. I mean, understanding those key and detailed molecular mechanisms through which the immune system allows or not melanomas to spread is such an important, that's sort of incredibly important work that will ultimately lead to improved ways to cure patients with melanoma, potentially by intervening fairly early to try and manipulate those immune mechanisms that will stop the disease spreading. So that brings us to the conclusion of the, so Katharina, I'll get you to sign off. Great, thank you so much. That brings us to the conclusion of the presentations. And so it really just remains for me to announce the winner of this year's Morgan Mansell Prize. En route to that, I'd just like to acknowledge Tori Ma and the team from the Victorian Melanoma Service at the Alfred for providing sort of oversight and administration around the award in the background. Particularly the prize assessors. The committee this year was Michael Henderson from Peter Mac, Andreas Barron from the Olivia Newton-John Cancer Research Institute, and Alex Chamberlain from the Alfred Hospital, Monash University. Thanks so much to these guys for taking the time and undertaking the basically impossible task of trying to separate the quality of the applicants. I think you can see from this snapshot of presentations that we have a really fantastic crop of young and emerging melanoma researchers working hard in clinical areas and also in laboratories. And these are the guys who are going to be the ones that usher in the next waves of innovation in the treatment of this disease. So thanks to the committee for taking on the task of picking the winner. And particularly, of course, thank you to Peter and Julie Mansell, who continue to stay engaged with MRV and who have made this award possible in their daughter's memory. Thank you so much. So without any further ado, it's my privilege to announce the winner of the 2021 Morgan Mansell Prize as our first speaker, Dr. Sophie Lim. Congratulations, Sophie. Excellent work. Tori has got the prize there, and I guess we'll figure out a way to get that to you somehow, because it won't fit through the cable. Great. So well done, Sophie, and well done to all the speakers, and indeed to all of the applicants. Really, again, it was a stellar crop of applications, and I think melanoma research in Victoria is in excellent hands. Thanks very much for your attention. I'll hand you back to Grant now.
Thank you very much, Mark, and congratulations to all the finalists. There's real cutting-edge work across all domains. And a special congratulations to Sophie. That really is molecular work that informs how a surgeon, performs their important work to cure melanocytic disease. So it's just beautiful work, and congratulations. Well, it just leaves me to thank everybody, especially our speakers tonight. But I also want to acknowledge our governance committee of the Melanoma Research Victoria that do a lot of work. And I think a number of people know the manager of Melanoma Research Victoria, Sonia Mailer. Sonia is an absolute powerhouse. She's the heart and soul of Melanoma Research Victoria. She's really helped drive really strong consumer reference group and consumer input to all of our activities. And we wouldn't be what we are with those over 3,400 participants without Sonia's hard work. So final thanks is to our participants. You're making a difference by being involved in Melanoma Research Victoria. You contribute vital knowledge, information, and biological characteristics of your tumours that really help other patients. And that's very generous and very visionary of you to be a part of the project. So, we all thank you very much. In fact, the whole world community in melanoma thanks you very much for being participants in MRV, because our research does get utilised, our data does get utilised throughout the world. So thank you so much for your contribution. So it just leaves me to wish everybody all the best for the forthcoming holiday season. I hope you get some real quality time with your family, friends and loved ones. We've been through a couple of tough years. Very much hope next year that our forum might be face-to-face, recognising also that we'll do our best to think about a hybrid situation too, where people can participate from right across the state and beyond. So thank you everybody for your participation this evening. Hope to see you soon. Stay safe and stay out of the sun. Thank you.